because I'm not just going to sit up here and go through the slide, I'm going to stop and we're just going to do an activity, which I'll explain in a few minutes once we get to that point. But just to give a background on autoimmune conditions, we have a couple terminology, a couple terms here to note. These, I almost took one of them out because I feel like the book is kind of, I don't feel like it differentiates these two phrases very well. So self-tolerance, yeah. Oh, really? Oh, you know what I did? I might have, I think if you read, can I see your slide? Oh, and it's called, yeah. So I might not have, either you downloaded it. Did you just download that just now? Oh, shoot. Why do I always do that? I update it and then I don't save the update. Let me see if it'll do it. Hold on. Let me just go to this and press save and see if it will. If I'm not logged into Box, so it's saving it and it looks like it's updating it in Box, which means that it should update it in Moodle. So if you go out and come back in, I didn't really make a lot of changes. I think that might have been the only thing I changed because I was just thinking about it last week and how to present it. And then that's when I was thinking about the activity. So I didn't make a lot of changes on this slide. So most of it's the same, but it should be updated now in Moodle. So, okay, so let me go back to where I was here. Okay, so yeah, so they're very similar terms. So self-tolerance recognizes the difference between self and a foreign antigen. So that's our immune system is set up so that we don't, eat ourselves. We just, go after things that shouldn't be there. But there are times when our body sort of malfunctions and we start to go after self cells. But we have these regulating processes in our body and in our immune system that's supposed to regulate that. So self-tolerance is one term where it's just the recognition, it differentiates between one and the other. And then immunologic tolerance, which I feel like says the same thing, to discriminate between one's own antigens. So I think the difference is it's talking about antigens specifically, I suppose, and non-self, which would typically be like microbe or bacteria or something that's coming into the body that's some kind of an invader or a non-self antigen. Very similar terms. And then autoimmunity, when the innate mechanism that normally prevents the immune system from attacking self antigens fails, activated T cells and antibodies begin to attack an individual's own tissue. So there's just a whole process that gets triggered, and all of those cells that would normally be directed towards something that's not self starts to be directed towards something that's, like our thyroid gland or skin cells or, just all various things. So conditions associated with autoimmunity are under an umbrella term of autoimmune conditions or autoimmune diseases. So there's two primary factors needed to develop an autoimmune condition. Sometimes it's inherited, like it's a genetic predisposition to an autoimmune condition, or it could be triggered by something out in the environment or a virus, or some kind of an infection or something. So an autoimmune disease often can be preceded, so it can happen after a really bad infection or some kind of a really bad condition. And then I put this in the notes. Well, I think this was already in the notes actually, which I think is interesting. They can see seasonal patterns of autoimmune flare-ups, such after the Epstein-Barr virus or Coxsackie viruses. They can lead to an uptick in diabetes type 1, and then what was the other one? Disease such as systemic lupus and diabetes type 1. So they can kind of track those. So those tend to be, they see an uptick in them after there's been sort of those seasonal episodes where those are more common, but when those tend to be seen more in the population. There's evidence of a variety of other environmental factors too. there's a lot of research on vitamin D and how vitamin D is so important for things like cancer, autoimmune conditions, as well as just fighting, just common viruses that we come into contact with on a regular basis. And then other things, exposure to UV radiation and melatonin, other things as well. There's always research on these different aspects. So autoimmune disease, so common characteristics, it's a cluster disorder presenting with more than one autoimmune disease, a multi-system involvement. So a lot of times when somebody has an autoimmune disease, there's several things, like the Sjogren's, for example, they might have, most common is dry eye and dry mouth, but they can have other parts of the body be affected as well, like even the lungs. And it can depend, severity can be, really severe for one person and mild for another person. So it just sort of can run the gamut with that sort of symptoms. General signs and symptoms, though, for a lot of autoimmune disease, they kind of can all fall under fatigue, joint pain, muscle aches, sleep disorders, anemia, psychiatric difficulties. Sometimes the psychiatric difficulty can be linked to the difficulty in diagnosis. So a lot of things can be hard to diagnose. And so if you're suffering with something, and say you just have joint pain and you're fatigued, but it's really debilitating, and nobody can put a finger on it, like pinpoint it, it can be really psychologically distressing, and so that a lot of times people can have a really hard time with diagnosis, and that can be really stressful. More than 100 different types of autoimmune diseases, so there's a lot of them, and a lot of times it's sort of dampening, suppressing the immune system, reducing inflammation. Those are some main medications and main ways to treat it, but there are some variations there as well. So medications used to treat autoimmune disease, if there's an anti-inflammatory category, then they might be prescribed something like aspirin, various NSAIDs. The COX-2 inhibitors, the only one on the market right now is Celebrex, and that's the one that is a little bit less irritating to the stomach than taking just like a naproxen or ibuprofen for long term. So if somebody's on an NSAID, they might, for long term, they might put them on a COX-2 inhibitor, like Celebrex, the only one. Corticosteroids, they could be on a prednisone or prednisolone. Those are different corticosteroids. And if they're on those for long term, they also have some side effects as well. But like a patient with myasthenia gravis, they would oftentimes put them on prednisone or prednisolone for indefinitely, for a really long time. They might try to taper it once they get the condition under control, but they are likely going to be on it for, the long term, really. And then there's another category of drugs called DMARDs. And I think we talked about these in oral med a little bit. We must have. Disease modifying anti-rheumatic drugs. So things like rheumatoid arthritis, things like that, or rheumatic fever. Immune modulators. So this is one category, immune modulators. Methotrexate, anti-cytokine therapies here. Anti-malarial, chloroquine or hydrochloroquine, and then penicillamine or gold compounds, and then immunosuppressants, which we hear a lot about, cyclosporin being a major one. So these are all common medications depending on their autoimmune disease. So, it's going to be probably specific to what they're dealing with, but these are all drugs. People with rheumatoid arthritis oftentimes are prescribed hydrochloroquine. So these are all medications that potentially could be used on someone with an autoimmune disease. Complications with chronic use of corticosteroid medications, insomnia, ulcers, ulcerations, peptic ulcerations, osteoporosis, cataracts, which can affect the eyes, glaucoma, also the eyes, growth suppression if it's given to a child, delayed wound healing. That's something that we would certainly be more concerned with psychosis, weight gain, adrenal insufficiency, and adrenal crisis. So those are, adrenal crisis is a problem if somebody's constantly having their cortisol levels, like the body sort of stops producing a lot of cortisol because it thinks, oh, I don't need to because of the corticosteroid that they're always on. And then if they actually are in a situation where they really need cortisol because if they're in like a high stress situation, which is what cortisol does in our bodies, it helps us deal with like a high stress, fear, pain. And if they're all of a sudden in this situation and they need it, but their body has sort of shut it off because of the long-term use of the corticosteroid, then they can go into adrenal crisis, which it could be deadly. It's super serious. So that's a category of somebody who's been on maybe high dose long-term corticosteroids. Other side effects of the medication. So there's lots of oral side effects from the drug therapy. Comprehensive pharmacological history is really important. So if you get somebody, like say you get somebody with lupus, or you have a patient, with, myasthenia gravis, which you won't see a ton of them, but you will definitely see a handful in your span of your whole career. Whenever you see somebody with an autoimmune condition that you haven't seen before, make sure you take up the time to look up the medications because it's going to be new. It's not going to be like a high blood pressure medicine that you see on virtually everybody. It's going to be, something new that you might not have seen for a while. And so look it up, look at the side effects. And this is just highlighting the like aspirin, NSAIDs, or the salicylates, which is like aspirin, NSAIDs, COX-2 inhibitors. They're associated with adverse bleeding, so they tend to be thin the blood, so that can increase bruising, gastrointestinal hemorrhaging, gingival bleeding. Lesions may occur in the oral mucosa, including the appearance of bluish or black pigmentation, so they can have some intraoral kind of hematoma. And then immunosuppressive drugs may cause gingival enlargement, or the opportunistic infection is the big one. If you don't know by the end of these 2 years that immunosuppressants can cause opportunistic infections, like that's guaranteed to be on your board. So just pin that, and you just have to, and cyclosporin is the one that can cause gingival enlargement. And then any immune suppressant can cause opportunistic infection, which is what's the main one that we think of? Candidiasis. So Candida albicans is an opportunistic infection. It's always in our bodies. We always have Candida, but it will grow, it will become imbalanced, and it will grow out of control if the opportunity places itself in such a way. So like if your body becomes weaker and can't sort of deal with it in a normal way, and it takes that opportunity and flourishes, and that's when you have the fungal infection, thrush, or any kind of candidal infection. Okay, so in general, care planning depends on the autoimmune disease and the diagnosis. Consider their physical demands. Somebody with, I keep going back to myasthenia gravis because I have had a couple patients, so I can pull from my actual experience, but they have weaker swallowing ability. They don't, oftentimes, they can't handle the ultrasonic as well. They might have just a harder time keeping their mouth open and dealing with the fluid. They might not feel or do as good a job with brushing. I had one patient that just didn't brush his molars as well, and he just had a hard time. And then I had a female who had a male and a female with it, and the female did fine with everything, but she had other issues. But he had his voice was weak. He had a harder time swallowing, and that was a real struggle with him. So you have to think of their specific situation. How is it manifesting? How is it affecting their dexterity, their ability to provide themselves with daily oral care, their ability to be in your chair and tolerate your cleaning? So just think of all those parameters. Possibly you might need a shorter appointment. You might need to assist them or support them in some way. Consult with a physician if it seems really uncontrolled. You can consult with a physician. unusual oral complaints or manifestations, make sure you make note of it and you can sort of like research it if it's something very unusual and you haven't had a patient with that condition before, and then consider the medications. So now we're going to stop here. So I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So 15 here. These are the ones we're going to work off of today. So everybody, Courtney, you're here. So we have all 32 of you, right? So then it should be what? Groups of 2 and then one groups of 3. Because somebody has to, am I doing that right? 32, because that's 16 if you all, but I only have 15. So I don't think so. Everyone's here, I think. So, or it's 2 of you. So, so then 2 of you. So there would be 2 groups of 3, right? Okay, good. Math is not my strong suit, y'all. So, so 2 groups of 3 and everyone else pair up. And then, but everyone gets a sheet because you'll want to just take one and pass it around and make sure everyone ends up with one. Okay, this one and pass it on. And I think I gave way more on this side than that side, so we're probably gonna. And then this one here, I'm gonna post. This is the worksheet for today, and it's a really short article. There's the link to it here, but obviously you can't click on this link. But I did print this out so you could write on it here. But I'm gonna post the link to the article in Moodle, or I might just, you know what I'm gonna do? I'm gonna share this Google Doc with you so that you can click into the Google Doc. So look for that in your email. This article from the RDHE Village, it says Sjogren's syndrome considerations during and after cosmetic dentistry. Very short article, like a 5-minute read. And then there's 2 questions here. So that'll be for later, and I'll share this Google Doc with you so you can actually click into the link. So once you have your paper, we're gonna take we're probably only gonna take like maybe 10-12 minutes for you to work in your group. And we're just gonna, I think I'm gonna we'll start on this side and we'll do, I'm just gonna assign them to you just because we don't have a lot of time. So you guys take adrenal and then chronic fatigue and cold pemphigoid. I don't even know how to say the first one. Fibromyalgia, so this is a 3. Where are you going, Jenny? You're over there. So you guys, fibromyalgia, hyperthyroidism for lactose fat, hypo. So you guys do hypo. MS, you guys do MS. And myasthenia gravis, pemphigoid vulgaris, and then have one. So I might need to. And then you guys are finished anemia. And then you guys, rheumatoid arthritis, Ashley, scleroderma, Sjogren's, and what happened? Did I miss? What did I miss? Oh, right. Who did I go to? Who had pernicious disease? Psoriasis, and then rheumatoid, and then scleroderma. You guys didn't get one yet? Oh, you were hiding behind there. So, Sjogren's. You guys do Sjogren's, and then, but why do I want one left? 3 groups of 3. There's 3 groups of 3? So no one's gonna do group it?
Wait, how about the both groups in 3? Make them group 2 and then the 2 pair up and sit down.
Okay, yes. Fabulous idea. So the the 2 groups of 3 make a group of 2 and take systemic lupus. And then, so that way everybody has all of them. And then just take like 10 or 12 minutes to look it up and just give like short, like what is it? Like the first question on there that says, you know, like what's going on? Synthesize it. Try to make it as, you know, as synthesized and brief as you can. And then look up the other two things. Yeah.
I was thinking if you could do it, I was thinking if you could add that to the photos, and then now we have everybody's information at once.
So people can
Yeah,
add
we
it
can add
in.
Yeah.
We can, so what I'll do is, I don't know, because people are writing it handwritten right now. So let me see, hold on. I can put that in a Google Doc. I just don't know. That many people typing it once into a Google Doc usually doesn't work because it's too many people it slows it up. But we are gonna get everyone's information. So are there extra charts, you guys? Because I printed 32, so everyone should have one. So here's the chart. No, just write it, because we're gonna share our findings. Nobody wants to share? And if we have any, okay, so let's start with the first one. Who had the adrenal insufficiency? So I'm not typing FYI because I see that you guys are already in it. So I'm not going to type anything. So who had adrenal insufficiency or Addison's disease? What'd you guys find out? So the body's suppressing the secretion of cortisol, right? So the main thing is that cortisol, which a lot of times we hear bad things about cortisol because when you're stressed, you're like always producing cortisol, and like this chronic exposure to cortisol is not great. But when your body's not producing it, that's not great either because we have these specific reasons. We have all this different stuff happening in our body, and when things get out of balance, it's no good. Okay, so suppressing cortisol. Macular pigmentations. Interesting. Okay. So hyperpigmentation on the palate and the lips from the constant like hydrocortisone or some kind of steroid use, cortisone, prednisone. Did it say anything about prednisone or prednisolone or just you saw that can be used? Okay, good. Thank you. Okay, chronic fatigue. Yeah. Mm-hmm. Mm. Mm-hmm. Mm. So it's probably maybe xerostomia if they have taking drugs that can induce that, or maybe just the chronic fatigue. It's doing something. And then if they're having pain, you can have pain everywhere, but they might have pain in the head, neck, jaw. Interesting. Yeah. Chronic fatigue is really an interesting topic. There's like a whole, I read a whole thing where they were talking about patients with AIDS and how oftentimes they have like chronic fatigue, but they're not diagnosed as such. And it was like a whole thing where those two things overlap. And I mean, I think people can have chronic fatigue and certainly not have AIDS. So that's not the point, but that those two things cross over quite often and mirror each other. And it's just like a big attack on your overall immune system. And that can be incredibly frustrating because to be tired and in pain and have like a hard time to get that diagnosed. Oh, there goes my battery. It's going to die. Okay, thank you. So, and how about this cicatricial? I don't even know if I say that first one, but pemphigoid. I know I say that one right. How about that one? What did you guys find out about that? Cicatricial? That sounds great. Cicatricial sounds better than whatever I said. Mm-hmm. Good. You can summarize because we probably are going to run out of time. So it's scarring in the oral mucosa. Niacinamide. Yeah. So difficulty opening. So you'll have a patient that won't have as much stretchiness. And then if they're losing bone, that's never a good thing. So that's pretty serious. Definitely very direct to oral care, right? And what's the next one? We have fibromyalgia. So obviously tons of crossover with chronic fatigue and fibromyalgia. Sort of, sometimes I think those two get said like they're the same thing. I don't know how often they get differentiated, but so xerostomia and then pain in the face. So very similar to CFS. And then the next, hyperthyroidism.
Before SCC, and there's blood things and they affect the metabolic rate. Drugs, we found the cyanide drugs, for example, metronidazole, which are short-term drugs to decrease the blood cells and they inhibit thyroid production. We also have the radioactive iodine, which is like a liquid or a drink that contains sodium iodine because we destroy also the overactive. Iodine just itself, but for thyroid definitely. And for common patients, we found that there's a mild tremor in the tongue. We're talking about how that be. And then also there's osteoporosis in the bones and jaw, and there's rapid progression of perio. And in children, there's an accelerated tooth eruption.
Interesting, because they're kind of running hot, right? Like, because it regulates sort of metabolic rate and it can affect blood pressure too and things like that. But they're kind of, you think of someone with hyperthyroidism as sort of running fast, running hot. Like so if things get like eruption happens sooner, or the tremor might be, they might be like jittery or have like extra energy. Sometimes they're thinner and like seem almost like they're like up or hyper, so that can be from the production of the thyroid gland. And so they're trying to dampen it or stop production with the radioactive the word just left my head. Iodine. Thank you. I was like, what is it? But yeah, radioactive iodine. So interesting. And then what about hypo? So now we have the opposite side.
The body is not producing thyroid hormone, insufficient amount of T4 and excess amount of TSH in the body. So basically, TSH is increased and T4 is decreased. So it causes decreased metabolic rate. And treatment they were hierarchical simply for life. And the oral manifestation say enlarged lung or microglobula, delayed eruption, small cell development in children, malnutrition, lingual thyroid tissue, more tremor of tongue, so personal stereotypic and voiceless, abnormal marks of thyroid.
So there's lots of things we might see. So it's like it, even in just the description, you hear that opposite, like everything is then slower. So it's, I always think of someone with hypo as like slow and cold, and hyper is like thin and fast, even though I know that doesn't always work out, but that's just how I remember the major kind of manifestation. But lots of oral stuff with the larger tongue, and then slower eruption if it's in child. And it's most common in women. And you will see more hypo, because a lot of times if somebody has hyper and say they've had to treat the thyroid, and like they end up like killing off or removing the thyroid gland, and then they have to give them synthetic thyroid hormone. So then they may go from hyper to hypo and then be on a medication regimen. So you'll see hypo far more commonly than you will hyper. Okay, and what's our next one? And then multiple sclerosis.
Okay, so this is when the myelin cells of the CNS are
Demyelinated. So that sort of protective layer, the myelin sheath.
Yes, the kind of broken down due to chronic inflammation, and it can cause communication problems between the brain and the rest of the body. It can also cause permanent damage. And then for treatment is anti-inflammatory medication, immunosuppressants, and steroids, also chemotherapy, and then some oral complications are, of course, xerostomia. They can get like numbness of the face and tingling of like the hands, feet, arms, predisposing to hemorrhage problems, stomatitis, candidiasis, ulcers, gingivitis,
Lots of stuff can go. Yeah, MS is another one of those where, well, like all of them, I mean, anyone can run the gamut on any of these with severity, but MS is when someone can be high functioning and have it under control, or like in a wheelchair and have tons of side effects or things like that. So it just all depends. And then a lot of those medications can cause side effects. So that's a good one to know, because there's a lot of potential oral side effects, just depending on what kind of, how much anti-inflammatory or immunosuppressant or steroid therapy that they're on. There was a show called not Survivor, not the main one, but it was another one where people went out in the wilderness and like they went to like super like the most like the Arctic or Siberia or some Alone. Did you guys watch? Did you like Alone?
Yeah.
I loved Alone, and that's probably like the last series. I never watched series because I just can't get that addicted, but I did watch almost all the Alones. And did you see the one lady who had MS, but she treat herself with like the herbs? Yes, but then she went to yes, she treated herself with all these different herbs that she knew. She was an herbalist. And so she was doing quite well, but then she came back for a second season, and they were, I think it was Siberia, and there was like nothing around. There was nothing that she could utilize, and she went in, and the stress and probably, multiple things, she went into a major attack, and she was practically paralyzed, and they had to haul her off. And who knows how much was drama for TV, because I know that happened, but it still was really interesting. And I was going to say something else about it, and now I spaced it. But in general, MS can have those periods of recession, it can be, what do you call it, when remission, and then those periods of activity. So MS can sort of come and go throughout. the lifespan of the disease. Okay, interesting. Thank you guys. Myasthenia gravis. That's it.
It's a rare chronic autoimmune neuromuscular disease. You would see in that using eyelids, muscle weakness of the face, kind of neck, as well as difficulty swallowing, chewing with impaired lip movement. Overall, there's a decrease in the ACH receptors, and that creates the error in transmitting nerve impulses to the muscles. Medicine, I can't pronounce the top one, but it's a new. The second one is neostigmine, and that helps improve muscle strength. It's short acting. And recently there was an FDA approved one called Vivgard or Vivgard.
That's a newer medicine.
Yeah, it's in 2022.
Oh.
It talks about like what it does on the cellular level, but it doesn't talk about, we weren't able to find anything that helps us what it does to help alleviate the symptoms.
Interesting. Okay. I can
Um,
look that up.
and it just causes tongue atrophy, muscle weakness, the head and neck, difficulty chewing, swallowing, soft palate weakness. It would make it more difficult for the disease to be able to take.
Yeah, so that one for sure, you'll notice lots of oral stuff if you have a patient with myasthenia gravis, and it'll depend on, again, their severity, but that's interesting to know. I'll have to look up a new medicine for that. But lots of, weakness, and so laying back can be hard for them. Using the ultrasonic can be hard, and then keeping their mouth open, sometimes talking too. My male patient he just got like tired talking. It was kind of, I think he just was stressed and fatigued. It was a new diagnosis for him. But anything else that you guys had to share? Was that it? Good job. Pemphigus vulgaris. Where did we go from there? I know I skipped you guys at first, so then I don't remember which one they got. Who got pemphigus? You guys got pemphigus? Pemphigus vulgaris.
It's just cause when like the immune system attacks the cells of the skin, then it causes like sores and blisters all over like the skin, the eyes, and the mouth. And so a medication that we prescribe is corticosteroids. And so if you have a mild case, then they just give you topical. But for like the more severe and involved cases, they give you oral pills like prednisone. And then we found that oral implications are like these ragged erosions, like ulcerations, like oral mucosa, nausea or vomiting from the medications itself. Cause more erosion.
Oh, yeah. And all of that would make it worse. I mean, like dry mouth would make it worse. Like you said, vomiting would make it worse. Did you guys talk about pemphigus vulgaris in oral pathology? I feel like that would have been in that class, but I don't know the syllabus or what material you guys cover, but it seems like it would. Okay, who had pernicious anemia? Pernicious anemia. You guys, pernicious anemia?
So it's a failure of the stomach to produce enzymes factors that lack down or vitamin B12. And so for medications, there's an infection of vitamin B via those bowel lines.
Is that just vitamin B, probably?
Yeah.
That's just the big chemical name for it.
Yeah, because you can be able to like take vitamin B supplements, but they recommend at least in the injections so you have to take so much vitamin B for that. So and then yeah. So glossitis. Also thyrosis, which is something for the tongue.
Oh, so burning tongue syndrome and glossitis, inflammation.
And oral ulceration.
And oral.
You just have like a slow disappearance of the filler form and the vine form.
So kind of a smooth denuding of the papilla. Okay, thank you. And then psoriasis.
Psoriasis is buildup of skin cells, and they form a scaly, like itchy dry patch on the skin. and it's triggered by infection, stress, and cold. Medications are topical and even steroids, vitamin A,
Vitamin A.
anti-inflammatory medications, and then oral infusions are rare, but you can see geographic tongue sometimes. Oral lesions are widely rare. Hospitals are less.
Interesting. Yeah, you don't usually think of psoriasis, or I mean, I kind of always think of psoriasis and eczema sort of in the same category, and you never think of that being an oral lesion. But if they can see signs. That's interesting.
I remember I had a friend who had geographic tongue, and she was trying to get tested for like autoimmune stuff, but it wasn't quite.
It was wasn't going on. It's hard. Lola she gets for eczema for sure since birth. She's had eczema, but I suspect psoriasis too because they're always in the same area and they're large and scaly. They're like a patch. It looks like a patch. Yeah.
So I was wondering with psoriasis. So a long time ago, my parents would always want to have a separate wedding, and the grandma would always put like Windex on everything.
Yes.
And so at one point, my mom had psoriasis, and she would pinch her elbows in Windex, and like a couple days later, it would just peel off and just
Seriously, it wouldn't like burn a hole in her elbow.
no.
That's crazy. What in the world? Ammonia?
No, Windex.
But it's Windex ammonia?
Yeah.
But is that what's in it, Windex? I'm trying to think what's in Windex. But I do remember that movie, he put Windex on. Like Windex cures everything. That's crazy. Maybe I'll try that on like a very small patch of Lola's skin. She got, I used a CeraVe, anti-itch CeraVe cream. Can't be the lotion, it has to be the cream. And then the doctor finally gave us a prescription. It's like a steroid. It's stronger than hydrocortisone. But man, she just gets tops of knees, backs of knees, ankles, inside her arm, elbow. The psoriasis. And it's so hard to clear up. It's like, yeah, that's the autoimmune fun of it all, I guess. Okay, rheumatoid arthritis. Who had rheumatoid arthritis? You did.
Rheumatoid arthritis is a chronic
So it's not just the joints, right? It's also can affect the internal organs. So crazy.
Yeah, medications are steroids. Some oral application is limited. Difficulty opening the mouth, so CNG problems, drug-induced physical bleeding, and oral mucosal.
And oral mucosal lesions. Good. Yeah, and that one's pretty common. You'll see a lot of patients with rheumatoid arthritis. Maybe not a lot, but I mean, it's one of the more, you'd probably see RA more than you would say pemphigoid, for example. So, but still, you can see how there's sort of an overlap. Like, there's not like a plethora. I mean, there's going to be some specifics, but for the most part, a lot of autoimmune conditions are treated with, to suppress the immune system and anti-inflammatories and pain medication. Okay, what's next? We have scleroderma. That's an interesting one, scleroderma. It's kind of similar in some ways to the pemphigoid, but all over the body. Who has scleroderma?
Yeah. So scleroderma is the chronic hardening contraction type skin and connective tissue. It's caused by swelling and the immune system attacking the connective tissue under the skin and around the internal organs and blood vessels. Medications are usually pain relief meds, which can be managed by non-steroidal anti-inflammatory medications supported with steroids. There is a few ones where there are the doctor says cyclosporin and methotrexate. Again, for like oral type medications, not medications, but some oral antimicrobial mouth rinses, salivary replacement therapies. And then for the oral implications, there's xerostonia, microstonia, widened periodontal ligament, osseous destruction of the TMJ, mandibular angle, condyle, limited mouth opening, generalized recession, firm hypomobile tongue, and an interior open.
This one is incredibly, what's the word? Yeah, like, there's a word I'm trying to think of, but I can't think of it. But it certainly would affect multiple areas of somebody's life. So, like there's a few here that if they have scleroderma, not only oral implications, but just like, I mean, their overall health, they're more of a sick individual, like they're really not well. Whereas like, there's some things where you might, nobody wants psoriasis, but generally speaking, it's not gonna affect your quality of life. Generally, I know there are some more severe cases, quite to the same extent that something like scleroderma could, and there's just many overlapping complications for when somebody has scleroderma. But of course, none of these are anything that anyone really wants to have. Where is this? And there's some of those pictures where you see where the person looks just totally taut, like tight. Everything looks shrunken and like stretched really tight. I think there's a picture of a patient in the slide deck here, but that's scleroderma, like limited opening. They lose a lot of structure and bone support and lots of systemic complications. No good. Okay, Sjogren's syndrome.
Sjogren's syndrome is a disease that happens and it's basically when your immune system attacks the salivary gland and the tear gland. So a person with Sjogren's will have varicella and dry eyes for the rest of their life from when they're diagnosed. It can be triggered by environmental factors like pollution, infection, diet, and medication. So medication that we use to help the disease is steroids for liver-producing inhibitors, so we said like xylitol or histidine, also NSAIDs and immunosuppressive drugs. So oral manifestations in the mouth would be dry mouth, enlarged salivary glands, and then we would have patients for caries, gingivitis, oral candidiasis, and caries.
Yeah, that one. It's like so many people get dry mouth from all the medications, but that's a condition that can just cause that just from the condition itself. And so we have to think of their risk for caries, but other things as well. So a lot of patients, you get very good at thinking of all the products out there that people can use for dry mouth, and not just because someone has an autoimmune condition like Sjogren's, but just for the myriad of medications. But they can take anti-inflammatories. Is that what you said too? Interesting. Okay, so the last one, systemic lupus, erythematosus. I said that wrong. Erythematosus. Yeah.
So this is a body attack on the organ of the body. Similar to MS, you can characterize like three of those flares, and then you see like a spectrum of. Then managed by immunosuppressive drugs like taurine and steroids. And then additionally, depending on the sensitivity to light, most patients sunblock or right. And then oral implications are oral ulcers, pain, erythema, hyperkeratosis, erythema, ulceration, and PCA. And then there's something called chronic cutaneous lupus erythematosus, which are painful lesions similar to a lichen planus.
Oh, okay. Interesting. Okay, so similar to lichen planus, erosive lichen planus. Interesting. Okay, good. So those are the ones that are fair game. Those are not the only autoimmune conditions out there. So the take-home point is, as clinicians, you will run into various things. Like it said in the beginning of the PowerPoint, there's 100 or more autoimmune conditions. But you can see kind of a general theme. So the main thing to think of when you're treating any patient is to learn about their condition. They're the expert. If I think maybe I saw one person with lupus in my whole career, but I saw many people with rheumatoid arthritis, many people with, I'm trying to think what else I saw, probably chronic fatigue or my fibromyalgia. hyperthyroidism. So there's going to be ones that you see more, but just talk to them about their condition, talk to them about the medications that they're taking, and make sure you look, if you have any, it's so easy. If they look healthy and they look fine and they're sitting in your chair and you don't think it's going to affect the next 45 minutes that you have with that patient, it's so easy to not look into it, but they could easily have something that's causing an oral lesion, dryness, any number of things that you could still give them assistance. You could still talk to them about it and help them, that they might not even realize would be something you could talk to them about. Like they might not bring it up, but it's so we don't oftentimes think to like pay attention to something if the person doesn't look really sick. But so that's why it's always good if, even if they don't seem like you're going to have to alter their care for any significant reason, it's still good to do a little research and talk to them about their condition. So all of basically this PowerPoint is fair game for the quiz. The next one that's coming up, I'm just going to thumb through this really fast just to see. You can use the information on this PowerPoint, but you can also refer back to what you guys gathered together as well. So most of this should all overlap. Just see if there's anything that stood out. I'm just gonna go through real quick. So yeah, so use this as probably as your main one for consistency, especially just since, when I write my questions, I usually write them straight off of the PowerPoint, but also you can utilize the table that you created to help study and memorize the material as well. Oh shoot, I meant to go back, hold on. So always thorough health history, oral pharmacological history, priorities, oral, medical, possibly need to postpone care if somebody's in a severe state of something. If they're having a major flare-up, they're probably not going to show up in your chair. But if they do, it's good to consider what, especially something like MS or rheumatoid arthritis, if they're having a big flare, how's that affecting their ability to perform their own oral hygiene care, to sit in your chair for 45 minutes, how's that going to affect all that? My battery's about to run out. Dental hygiene may aid in oh my word, it's gone. That's it. And that means the Zoom's gone too.